Hello everyone, welcome back to my channel. I am Dr. Soumita Roy, pediatrician, and today we are going to discuss an extremely important topic for your exam, and that is neonatal jaundice. So, why this is important, students? Because you are going to get lot of questions both in theory as well as viva from this particular topic. And yes, before reading neonatal jaundice, you should definitely go for bilirubin metabolism, for which I am already having a separate video uploaded. Okay, so let's begin with the neonatal jaundice. So, as you know, students, neonatal jaundice is the most common cause of morbidity in the first week of life, right? And 80% of all preterm babies and 60% of all term babies are having neonatal jaundice. Okay, so most of them are definitely physiological and very rare, like only 3 to 5% are pathological, right? Yes. So, and what is neonatal jaundice or neonatal hyperbilirubinemia, students? So, if the total bilirubin is more than 95th percentile as per age specific Bhutani nomogram, right? So, that defines your neonatal hyperbilirubinemia. Okay, so next, moving on to the physiological basis of neonatal jaundice. Okay, rather the mechanisms. Okay, why this neonatal jaundice develops. Okay, so first is the due to more production of bilirubin, right? So why this happens? It may happen due to more ineffective erythropoiesis, okay, or this also may be due to low RBC lifespan, okay. Next mechanism is, if you have already read the bilirubin metabolism, this is going to be very easy for you, okay, students. So the next mechanism is if there is reduced hepatic uptake. So how there is reduced hepatic output? Due to low level of ligandin Y protein. Okay. Next is due to defective hepatic metabolism. How? Due to lower level of UGT1A1 enzyme. Okay. Why? As you know, students, this helps in conjugation of bilirubin. Yes. And the fourth mechanism is increased enterohepatic circulation. Yes. How can this happen? Due to reduced beta glucuronidase enzyme, or due to less number of intestinal gut flora. Okay. So these are the mechanisms, physiological mechanisms of developing neonatal jaundice. Clear? Next, moving on to the assessment of neonatal jaundice. Okay, how you are going to assess? So basically, you need to remember one thing, students. Neonatal jaundice occurs, or the direction is cephalocaudal. So what do you mean by cephalocaudal? It starts with the head region and it moves on to the lower part of the body, right? Okay, so here we are having something called Cramer's rule. Clear? Cramer's rule. So this is often asked in Viva. So basically, when you are seeing jaundice in icterus in the face, the serum bilirubin level will be something near about 5 to 6. Okay. Next, if you are seeing John icterus still chest, the serum bilirubin level will be somewhere around 6 to 10. If it is in between the abdomen and the upper thigh region, then it is going to be 10 to 12. Okay, if it is in the lower legs, then it is 12 to 15, and if it has stained the palm and the sole, then it is of course more than 15. Clear? So this is the Kramer's rule. So do not forget, students, and it's very easy. You see, 5 to 6, 6 to 10, 10 to 12, 12 to 15, more than 15. Right? Now, let's move on to the causes or etiology of jaundice, neonatal jaundice. Okay? So many a times this question has been asked, and one more question which is repeatedly being asked is the causes of jaundice in first 24 hours of life. So what are these? Basically, definitely it is something called pathological jaundice, not physiological. And after this, I'll be telling you the difference between pathological and physiological jaundice. Okay. So first thing you should remember is first point is hemolytic disease of newborn. This is not hemorrhagic disease of newborn students. This is hemolytic disease of newborn. And why does this happen? Due to blood group incompatibility. Okay, first point you should always write this one. This is because it is the commonest. Okay, next. This may be due to some rare cause like G6PD deficiency, hereditary spherocytosis, intrauterine infections, okay, Krigler-Najjar syndrome, or it may be due to alpha thalassemia. So these are the causes of neonatal jaundice developing in the first 24 hours of life. Okay. So what are the other causes, students? Or you may put up in this way, the jaundice which develops after 24 hours of life. So first will be physiological jaundice, yes, and it may be due to the, like, septicemia, breast milk jaundice, breastfeeding jaundice. So what is the difference between breast milk, breastfeeding jaundice? I'll be having a separate session on that. Okay, due to some cephal hematoma or some concealed hemorrhage. Okay, this may be due to hypothyroidism. Okay, or it may be also due to, okay, metabolic disorders, right? So these are the causes of developing jaundice after 24 hours of life. Next, moving on to the difference between physiological and pathological jaundice. Okay, so what are the difference? First, let me tell you the criteria for physiological jaundice. This will develop after 24 hours of life. So basically between 2 to 3 days of life it appears. Okay, peaks at around 3 to 5 days of life. Okay, the serum bilirubin is never above 15, so always below 15. Okay, this is, yes, unconjugated hyperbilirubinemia. Okay, and the rate of rise is below 5 gram per dl per day. Okay, and this will disappear after within 10 to 14 days. Okay, so these are the criteria of physiological jaundice. So next, moving on to the criteria for pathological jaundice, often asked, okay, in viva. So this appears within first day of life. Okay, the serum bilirubin goes above 15 gram per dl. Okay, so it stains palm and sole. If you're remembering Kramer's rule, you can understand it stains palm and sole means more than 15. Okay, if there is conjugated hyperbilirubinemia. So what do you mean by that? If the amount of conjugated bilirubin is more than 1.5 to 2 gram per dl. Okay, and this will persist longer, of course, more than 14 days in term and more than 3 weeks or 21 days in preterm, right? And the rate of rise is, yes, it is more than 5 gram per dl per day. Clear? Next, moving on to the workup. So, how are you going to work up a case of neonatal jaundice? Okay, so first you have to take a detailed history from mother. Okay, the perinatal history. Okay, so what you are going to ask students? Yes, what is the birth weight of the child? I mean, was it a preterm baby? Okay, whether the mother suffered from any intrauterine infection, like you have to ask whether the mother suffered from any febrile illness with rashes, because that will point towards torch infection. Okay, whether there was any history of delayed cord clamping, why there will be polycythemia. Okay, and so on. Next, after history, you will be doing a proper physical examination of the child, like you should look for any cephal hematoma. Okay, what is the weight? Is it an SGA baby? Is it a preterm baby? Whether the child is having any petechial rash, okay, any polycythemia, okay, any signs of sepsis, and any hepatosplenomegaly pointed towards any metabolic disease as well. Okay, so after taking the history properly and doing a physical examination, you should go for the lab tests. Okay, so what are the lab tests you are going to do? Yes, definitely you should order blood grouping of both mother and baby. This is very important, students, not only of baby but mother and baby, right? Next, you should definitely go for a total serum bilirubin. Okay, and that will show you both the values of conjugated and unconjugated bilirubin as well. Okay, you should go for the G6PD level. Okay, these are the few things which you should definitely do, students. Okay, thyroid profile. If you're suspecting torch, you may order. Okay, and if you are suspecting some inborn error of metabolism, you have to order that particular enzyme level. Okay, so these are the basic things you should definitely do, right? Next, after you have reached your diagnosis that what is the cause of jaundice, you have to plan a treatment, right? So first line of treatment is phototherapy. Okay. So details of phototherapy, I'll be uploading a separate video on that. Okay. So mechanism of action of phototherapy. Okay. One is the lights used. So mostly it is used LED. These are the most effective. Then CFL, chlorofluorescent lamps. Okay. Fiber optic source, so these are the lights used. Okay. Next, what is the distance? You should keep the baby. It's near about 30 centimeter. Okay. What is the mechanism of action of phototherapy? So there is something called photoisomerization, where the bilirubin gets converted to lumirubin, which is excreted through urine. Next is the structural isomerization. Okay, and there is something called photo oxidation. Clear? So these are the mechanisms of action of phototherapy. And what are the side effects of phototherapy? Yes, baby may develop some rash, some loose stool. Okay, there may be hyper or hypothermia. Okay, and something called bronze baby syndrome if phototherapy is administered to a case of conjugated hyperbilirubinemia. Okay, and the only contraindication of giving phototherapy is porphyria, right? Okay, so the next line of management is exchange transfusion. So what we do is basically we go for a double volume exchange transfusion where we the amount of blood taken is 160 to 180 ml per kg. Okay, and what is the indication of exchange transfusion? If the cord bilirubin level is more than 5 or the cord hemoglobin level is below 10, then definitely you should do exchange transfusion. Okay, and what are the other therapies for treating neonatal jaundice students? Yes, there is something called sunlight, but it is controversial due to the side effect. Okay, next, the drugs or pharmacological therapy. So basically, many a times this pharmacological therapy has been asked in your PG. Okay, so what are this? You may administer IVIG. Okay, at a dose of 0. It's a low dose gram per kg. Okay, there is something called metalloporphyrins you may give of tin or zinc metalloporphyrins. Okay, and some rare drugs called, it's phenobarbital. It's given in Wigler-Najas syndrome. Okay, and very important, this you have to mention, IV hydration. This is very very important. Okay, so this is all about the treatment of neonatal jaundice. Okay, students, next, there are certain things, something called prolonged jaundice. So, what is prolonged jaundice? If there is jaundice persisting for more than 2 weeks in term and more than 3 weeks in preterm babies, then this is called something called prolonged jaundice. Okay, you may have a separate question on prolonged jaundice for PG, so if you want I can upload a separate video on that. Okay, and one important thing which is asked, that is BIND. What is BIND, students? Bilirubin induced neurological dysfunction. This is BIND. Okay, so for this also I'll be having a separate session because this may be asked as a short note, right? So that's all about neonatal jaundice, students. Hope this session was useful to you, and we'll be meeting soon again with a lot more important topics. Thank you for watching the video.